Hello and welcome to ThePrint. I am Sumi Sukanya Dutta and you are watching Health and You. So we are all aware that there is a growing pitch around obesity in India and rightly so. 254 million Indians, or nearly 28% of our population, is now considered obese. This is huge. And as the crisis grows, thankfully, we also have some options available to manage the condition, which is not only a cosmetic concern, but also a major health issue. To discuss everything around obesity and two blockbuster drugs which have recently been launched in India within a span of few months, we have with us Dr. Ambrish Mithal and Dr. Rajiv Kovil. Dr. Mithal is chairman and head endocrinology and diabetes with Max Super Speciality Hospital in Delhi, and Dr. Kovil is founder Dr. Kovil's Diabetes in Mumbai. Thank you so much, Dr. Mithal and Dr. Kovil, for joining us in this conversation today. Dr. Mithal, you have just written the book which has been launched about this. The book is called The Weight Loss Revolution. It has just hit the market, hit the stands. So tell us about the book first, because this is very similar to the theme that we are discussing today. And how and why did you decide to write about this theme, and what is the book about?
Over the last couple of years, we've been using these drugs, these weight loss molecules, which are for us basically anti-diabetic molecules, but which have profound weight loss effects.
Right.
So they hadn't yet arrived in India, but we knew that they're going to appear in India towards April and towards June, this period. So I was getting a whole lot of queries, and there were so many myths and misconceptions floating around on the internet, ranging on one extreme to, these drugs being the answer to all our ills,
Right.
to the other extreme that, oh, don't touch them, there are too many side effects. So I thought I should pen down the science
Right.
in a relatively simple language as much as I can for everyone to understand that the truth, as usual, lies somewhere in between.
Yes.
So that is the reason. So I put it in mainly a conversational style, and that's
Okay.
the idea.
Okay. So tell us a little about, how do you see the problem of obesity? We know that for a fact that it's driven by our changing lifestyle pattern and dietary patterns. But why suddenly there is near an explosion of cases, and how do you see it?
So I think the problem of obesity in India has been rising for at least 20 years. It's not that sudden. We talk all the time. You and I have also talked about rising diabetes. So diabetes and obesity rise in parallel. In fact, obesity rises. Uh, Obesity is the precursor for diabetes. So there is a rise in obesity, and then there's a rise in diabetes, rise in blood pressure, rise in heart disease. All those things happen. So increasing obesity in India has been a major concern over the last 2 decades. It has, of course, accelerated recently. It's linked to all our lifestyle changes, etc. Now, the issue here is that Indians tend to put on weight around the belly or around the organs, around the viscera, and that fat is the so-called bad fat. So all fat is not the same. The fat you have on your upper arms, for example, or thighs is not as bad as the fat that you have around your liver or the organs inside. And Indians have a propensity to put on fat in the center. That is the central or visceral fat.
Has to
So
do with genetic predisposition. What exactly is the reason for this?
it's not so much to do with genetic predisposition. We don't know that. We haven't proven that. But it has to do with centuries of malnutrition, and then followed by exposure to energy dense food all around. Suddenly intakes increase, and the food that is easily available is high energy but high fat and high carbohydrate, so not healthy food. So that quickly accumulates around our bellies, and that's why obesity actually in India has always been there, has increased recently, and may not always be visible. It's not like the fat person that you would see in the Western world. You don't see too many of those. You see people who are not that fat, but they tend to have a lot of the bad,
That.
bad
Yeah.
variety of. Yeah.
Yeah, yeah. So now coming to these two drugs that we are going to talk about, Wegovy and Mounjaro, which have just arrived in India. Could you simplify how exactly do these work? Do these drugs work?
Well, yes. So the explosion of interest in the last few months is linked to the noise around these drugs, the ones you're talking about, because they've taken the Western world by storm. It is thought that
Mm-hmm.
20% of Americans have been exposed to one or other of these drugs in the last couple of years. So it's huge, huge, huge. Now, what these drugs essentially do, they act through the GLP-1 pathway. So what is GLP-1? GLP-1 is a hormone secreted from the gut, from the intestine, and it stimulates the pancreas to secrete insulin, suppress glucagon, whatever, manage our blood glucose. But it also goes to the brain, and it goes to the brain and reduces our appetite, improves our satiety. So, in other
Mm-hmm.
words, reduces our food intake. Now, these drugs mimic the GLP-1, the endogenous GLP-1, the one that is circulating in our body. And they are powerful, in some ways more powerful than the one that's circulating in our body, in the sense that they have a powerful brain action, and therefore they actually can very significantly impact our appetite and therefore lead to weight loss, fat loss, and all the subsequent benefits. So it's a GLP-1 pathway that's important. Munjaro, or tirzepatide, also has an action on the GIP pathway, but the central action is GLP.
Okay. So you mentioned about your book earlier that it's primarily to dispel the myths around the side effects and who can use these drugs. Can you now talk a little about side effects, because concern in India is also that now the drug is going to be available across pharmacies. Anybody can just walk in, because we know how regulation around drugs work in India. Anybody can just go to a pharmacist and ask for it, the drug, and it can be easily accessed.
I think that's a genuine fear. I think we will need tight regulation for sale of these drugs, because these drugs are drugs, and they have to be
Mhm.
sold under strict medical supervision on medical prescription. And those are the guidelines. So hopefully they'll be implemented. So if you use the drugs under medical supervision, you are much less likely to get into trouble. But if you use them randomly and the wrong dosing, and just to lose 2 kilograms before a wedding, or something like that. I mean, and those requests are not unusual, by the way. So
Mhm.
that can lead you into a lot of trouble. So, for
Okay.
example, the side effects that can happen. Number one is, of course, the gastrointestinal side effects: nausea, vomiting, diarrhea, constipation. All of them can happen, especially if you increase the dose too rapidly without medical consultation. So the dose has to be built up very gradually. Start with a low dose, then increase, because people are in a hurry to lose weight, so they'll do anything to lose weight. At that moment they'll say, it doesn't matter if I vomit a little extra, but so long as I'm losing weight. So I think it's important that we do it right, that is, start slow and go upwards gradually. Now, the other thing is that this is, of course, the acute side effects. They are usually transient. They wear off in a few weeks, and they are managed by usual day-to-day things. An anti-emetic drug for nausea, or vomiting, or something for diarrhea. There's no specific medication, but to reduce these effects, and this is important because these effects are by far the most common. To reduce these effects, you have to take small meals. Even if at that particular time of the day your appetite is worked up, you haven't eaten for 14 hours, you're feeling hungry. But if you take a large meal, you'll feel sick. So
Yeah.
you have to have small portions. That's number one. Number two is plenty of water. Number three
Mhm.
is enough protein and fiber. Number four is, we also advocate walking, or staying upright for 5-7 minutes after every meal.
Okay.
That also helps. So these little things, they make a difference to the gastro side effects. And long-term side effects, of course, are different. We can talk about if you like.
Yeah, so there has also been concern about, in rare cases, I must emphasize on that point, of stomach paralysis in some people. in very few people, though there hasn't been any reported case in India, despite Ribelsus, which is also semaglutide in low dose being used in India for last 3 years now, and also with tirzepatide earlier. So would you like to talk a little about that? What are the
Yes.
concerns around that?
So I think gastric paralysis is actually, these drugs produce mild degree of gastric paresis, if you will. They
Mhm.
reduce the stomach motility. That's one of the actions. That's not really
Okay.
in that sense a side effect. That's how they
Mhm.
act. So reducing that, if they overdo it, if someone's stomach is already compromised because of 30 years of diabetes, then those people can get gastric paralysis, but you will get some warning signals. You will get you'll get enough notice usually, and if you're careful and if you report those to your doctor, the dose should be stopped or reduced immediately. This becomes a problem in anesthesia, because if someone has to undergo anesthesia, then you're sort of made unconscious, and the food, if it's still lying in the stomach, can come back into your throat and into your lungs, right? So it is very important, if you have to undergo any procedure under general anesthesia, tell your doctor if you're on GLP-1 drugs, because those drugs have to be stopped before the procedure. So you
Okay.
have to miss a dose before the procedure because of the risk of gastric paralysis. So that is very, very rare, but you can't take that chance.
So we have been having this conversation around obesity, and sir has just launched his book. So we were also talking about his book bit, and these drugs also. Obviously, there is a lot of excitement around Wegovy and
Absolutely.
Mounjaro now being available
Absolutely.
in India. So would you like to say something about how do you think that physicians like you have these tools now to treat your patients? Which are the
I,
kind of patients who can actually benefit?
I think the obesity is the root cause of all NCDs. That is something that we all have to recognize. And lifestyle dietary measures actually fail because the brain itself tries to sabotage weight loss by making you crave for more food. So these drugs are added to a good lifestyle, and what we see is that half of the world population would be overweight or obese by 2035. So we are not looking at a small problem. We're looking at half of mankind being overweight or obese. And even if out of that 50%, if we are able to treat 10% and prevent outcomes on them, then we are doing a great job. And whether we should take a drug to lose weight or whether we can do natural, now these are things that one can keep debating, and lives and years will go on and outcomes will not change. So here and it's not a shortcut also. It's chronic weight management. It's over a long period of time. It has to be. There are a lot of pros and cons. The expert should decide whether you fit the right criteria for the drug. It has to be stepped up in a very slow fashion. It has to up titrate it based on your symptoms. So there's a lot of science to these drugs, and a lot of these hormones are mapping a lot of parts of the brain, which is controlling a satiety and craving. And as you see in the next, I think 4 or 5 years, we're going to get more and more and more, and it will get more and more confusing also. So we've just
Right.
started on it, I would say.
Yeah. Dr. Mithal, you had spoken about it, while talking about your book also at the launch of this drug, Wegovy. But could you please also clarify for our viewers if a patient with, say, diabetes or without diabetes, but a certain BMI reaches at your clinic, so who is the right candidate who can be considered for these kind of medications?
Yeah. So at the moment, our authorities have approved it for those without any comorbidities, without diabetes, for BMI of over 30. So anyone
Mm-hmm.
with a BMI of over 30 is a candidate for these molecules. For those with comorbidities, and we are especially referring to diabetes, for example, 27 is the cutoff of BMI that is recommended. So
Okay.
you can consider these drugs at a BMI of 27, 28, 29. If the person has diabetes, you can consider them for anybody above BMI, who has a BMI above 30. So that is a whole it's a very large group of urban population. In urban surroundings, these numbers are not big at all. And even though there is a case to be made that these are based on Western criteria, and the fact that Indians actually get complications of obesity at a lower BMI, and BMI may
Right.
not be the way for us to look at obesity in India. So even if you look at that, we probably over the years will start treating people with lower BMIs also. But for the
Yeah.
moment, this is what it is.
Yeah.
Sure.
So waist size and hip to
Yes,
waist ratio is
that's right.
what could be the deciding criteria as we go
And,
ahead.
and if you're going to use these kind of drugs, I think doing a body composition analysis is a no-brainer. I mean, I think a BCA would be part of any obesity program now. You can't have an obesity program just on a BMI. So a
Yeah.
BCA would be very important. It's not a difficult machine. It's not a complicated technology. It can be installed anywhere, and hopefully the prices will also come down as they become more and more popular.
Sure.
Right. Yeah, Dr. Kovil, now we have seen in any country that wherever these two drugs particularly have been available, there has been nearly a head-to-head competition. Both the drugs are always competing with each other to get dominate the obesity management space. So now, coming if a patient, for example, walks in your clinic has a BMI of 30 or above, as Dr. Mithal said, what would be your preference if you have to choose or advise between any of these drugs? Will it vary from patient to patient? How exactly will you make your decision?
So at the onset, that competition also brings out a lot of innovation. So that's very good to
Right.
have. You know, to there's a very clear-cut guidelines, at least in our minds, when we look at these two drugs. And it's all based on scientific evidence. It's not based on our own clinical knowledge of the drug. So right now, with tirzepatide and Mounjaro, there's lack of evidence in terms of cardiovascular outcomes. So if I have a patient who is looking only at weight loss, and my preference would be to a tirzepatide or Mounjaro for that matter, and the data is also there that in a head-to-head study, tirzepatide was superior to injectable semaglutide. But if I have a patient who majority we don't have garden variety patients, we have patients who have
Mhm.
issues with them and issues driven by obesity. So it could be hypertension, diabetes, dyslipidemia, OSA, osteoarthritis, and majority are those. And uh, injection semaglutide has got more data when it comes to obesity with cardiovascular complications, and there's a good 20% reduction in major cardiovascular events. So if I have a patient with comorbidity and obese, I would go towards a Wegovy. And if he's looking at only looking good, and maybe the data for tirzepatide will also come eventually, but we will wait for it to come before we actually put it into practice. So very clear cut distinction right now, and and I think for the next 1 or 2 years, this is going to be the clear cut distinction when we look at patients with overweight or obesity.
Yeah, very interesting points there. Dr. Mithil, what would you say?
No, I think this is very interesting, but this is all a work in progress. As
Mhm.
Rajiv said, I mean, there's a lot of stuff coming out on this. For example, uh, higher doses of semaglutide are already being tried, and they may match up to tirzepatide. So, firstly, the difference is not hugely striking, but the fact is, yes, at the currently recommended dosages and strengths, it does seem that tirzepatide has slightly more weight reducing action than semaglutide. And this has been shown in some head-to-head studies at the currently available doses. But also remember that at some level, tirzepatide is acting through two pathways. So there is a slight difference. So you've
Mhm.
gone, I think you maxed out on the GLP-1 pathway alone with semaglutide. You can't, I suppose you can't do too much more with that pathway. So the GLP-1 pathway remains central. People have added GIP to that to develop tirzepatide, and they are adding all kinds of things, glucagon, this. So this is just the beginning, Sumi. You'll see an explosion of molecules over the next 5 years, and very good for our patients, very exciting for us.
Yeah, exciting times ahead. Really, thank you so much both of you for joining us the conversation today. To our viewers, we have a message that talk to your doctors before you
Yes,
even consider,
Absolutely.
that's a very important point. Yes. Thank you so much, Dr. Mithal and Dr. Kovil. Really
Thank you so much.
appreciate the
Thank you.
thank
opportunity.
you.